It's fine. I first of all want to make my congratulations for the 10th anniversary of Ortho Partner, a great company of a great man, Charlie. Thank you for all you doing for Ortho, and thank you for the invitation. I'm very glad to be here in the New York University. I skipped my curricula, and I just to let someone that doesn't know that I'm from Bari, from the south of Italy, from Puglia, a very nice region in the very south of Italy, south east. And those are some of my clinics where I do ortho. I can say I'm the consultant of all my clinics, and that's my life, a mix of clinic and university, together with different university around the world, and that gives me the chance to travel around the world, having the chance to meet very nice people. Let's try to focus on this new this theme, this subject, the sleep apnea. The obstructive sleep apnea syndrome is a disorder of breathing during sleep characterized by prolonged partial upper airways obstruction and or intermittent complete obstruction that disrupts normal ventilation during sleep. The Ministry of Health of Italy have given a role to dentists to recognize any signs and symptoms within its competence attributable to snoring and apnea syndrome, obstructive in sleep in the developmental age. That seems that the politics sometimes go quicker than clinicians, and they underline the importance of dentists, in particular of orthodontists. We have a role as to follow in case of patient in developmental age with suspicion of snoring or obstructive apnea syndrome in sleep, and we have to suggest and we have to follow a multidisciplinary approach. OSA's prevalence has two peaks period. The first peaks occur in children from 2 to 8 years of age due to the presence of enlarged adenoid and or tonsils. And the second peak occurs during adolescence in relation with weight gain. And we, in this period, as orthodontists, we follow those patients. So we have to underline if there's a suspicion of sleep apnea. There are anatomical and pathophysiological conditions in which it's more common to have sleep apnea, and those are the small mandible and the obese range. In a small and shallow mandible is an independent risk factor for sleep apnea, as told in this article. There are different anatomical structure that seems to be involved, and there's a new approach. Although the CPAP is currently treatment of choice, irrespective and of underlying cause, treatments based on tackling individual pathogenic mechanism might prove a successful alternative approach in the future, and we have to work on this. The treatment is multidisciplinary and include the following: lifestyle changes, in particular weight loss in obese subjects, pharmacological agents such as topical nasal steroids, antibiotics, decongestionants, adenotonsillectomy, continuous positive airway pressure, CPAP, and last but not least, the orthodontic treatment. Rapid maxillary expansion, myofunctional devices, and mandibular advancement devices can be used. First, the myofunctional therapy that probably reduces daytime sleepiness and may increase sleep quality in short term. We have to focus on this because the certainty of the evidence for all comparison ranges from moderate to very low, mainly due to lack of blending of the assessors of subjective outcomes, incomplete outcome data, and imprecision. For what concerns the rapid palatal expansion, it increases the maxillary transverse diameter, as we all know, increases the volumetric space of nasal cavities, decreases nasal resistance, facilitates the passage of air through the nose, raises tongue posture, enlarges the pharyngeal airway, and reduces relatively the tonsillar hypertrophy. There are different articles on this. The likelihood of an individual having ulcers appears to decrease as the volume of the palate increases, but increase as the lingual measure increases. This original article says that maxillary expansion can be a treatment option for improving the respiratory parameters in children with sleep disordered breathing. Also, this approach, this article we published in 2021, is a new very easy way of expanding, digitally measuring how much expansion we want to reach with a device that is metal-free and is very well accepted by the patients. Let's go on the mandibular advancement devices. These devices change the position of the tongue and widen the oropharynx space. There are different articles supporting this way of treating patients. One, in particular, this one of Dr. Kikuchi, proposes the hypothesis that the negative pressure produced in the chest prohibits the growth of the mandible, even if patients have a capacity for growth and development. Therefore, if this negative pressure disappears because of the removal of the tonsil and or adenoids or by an orthodontic treatment to make a patency of the airway, the mandible may grow normally, and we can prevent or reduce a number of OSAS syndrome in the future. Functional appliances stimulate mandibular growth by forward mandible positioning are an alternative therapeutic option for this syndrome. For this article, and the twin block seems to be a very good appliance that may be effective for treating pediatric OSAS. Considering all this, but focusing on the Cochrane, until now there is insufficient evidence to support or refute the effectiveness of oral appliances and functional orthopedic appliances for the treatment of obstructive sleep apnea and syndromes. So we have to study and do research. Oral appliances of functional orthopedic may be considered in specific case as an auxiliary in treatment of children who have craniofacial anomalies, which are a risk factor for apnea. That means that we have to do our work, orthodontic work, in specific case that need ortho, considering also this medical aspect. There's a big debate on the American journal and also the European journal, and there's this special article that reminds us that we cannot misinform the public and scare families into believing that their children will develop this condition of OSAS, but we can do something, and we can work on this. Kevin O'Brien says us that OSAS is more than a simple anatomical condition that can be prevented, induced, or treated by changing the dentofacial complex shape, size, or position. So we have to work on this more in deeply. And there are different courses, there are different situations. As orthodontists, what I suggest to do, we all know that class 2 malocclusion is a mix of different conditions of a retruded mandible or protruded maxilla, but there is also the vertical condition. We have different class 2 malocclusions that has to be treated in different ways. So we have to consider the true sagittal classical 2 and pay attention to the vertical component. But we believe in 3 specific concepts: the functional matrix hypothesis, the jumping of the bite, and the alveolar bore formation. Let's focus on these 3 subjects. We all know that Melvin Moss introduced the functional matrix hypothesis, for which we can work on our arches and on the tongue. And if we stand on the functional matrix hypothesis, we can manage not only growth of the mandible, but also the craniofacial skeleton as well. We need to give importance to the tongue, and we know the tongue has a very high importance. If not, we cannot treat these patients by controlling the tongue in the best way. And we really like this kind of functional appliances that control the muscles outside and inside the arches. When mandibular growth tends to grow, the mandible anteriorly, if we don't do anything, the occlusion provides a force system that maintains the class 2 by moving the upper teeth forward and the lower teeth distally. So we have to jump the bite. Jump the bite is something that we can do functionally, and then after the jumping the bite and having a new mandibular position, we have a new proprioception that we have to maintain by using fixed appliance. That's something that it's very difficult to do with aligners. That's why we like functional appliances in the first part of the treatment, and we control the new proprioception by using fixed appliance and fixing and stabilizing the class 1 we have obtained. After having controlled the class, having obtained the class 1, there will be bone apposition, and we will have a new occlusion, stable occlusion. What is the most unknown at the base of the craniofacial develop? The human evolution. Let's give a look on the human evolution, and in particular to the speech. And a long popular theory on the development of the larynx, first advanced in 60s, held that an evolutionary shift in throat structure was that enabled modern humans to begin speaking. The human larynx is much lower relative to cervical vertebrae than that of our ancestors and other primates. The descent of the larynx was what elongated our vocal tract and enabled modern humans to be making the contrasting vowel sounds that we are early building blocks of language. So what Damian Blasi and Stephen Moran of the University of Zurich affirms is that speech sounds that we use has not necessarily remained stable since the emergence of our species, but rather the immense diversity of speech sounds that we find today would be the product of a complex interplay of factors involving biological changes. In particular, we have a descent of the larynx that gives us the chance to speak. And that why I'm telling you this, because this gives problems of snoring. And to solve the problems of snoring, of this position of the larynx that is more back than in the monkeys, we have a very good solutions that are functional appliances. But what is important is to use the one that works properly in a specific malocclusion. It is important to know how they work, the effects that we still don't know, to know the proper design that we have used, and to know the proper indication and the limits. But sometimes someone says they don't work. Do they work? The question is, do they work? If we base on the rapid palatal expansion, we all know that it works. Raising the tongue posture, enlarging the pharyngeal airways, and reducing relatively the tonsillar hypertrophy. Nobody can say that is untrue. What about the mandibular advancement? Histological animal studies have shown that the temporal bone of the glenoid fossa adapts to the protrusive function through a reversal of the normal growth pattern with bone formation along the anterior border and bone resorption on the posterior border, exactly here. The effectiveness of functional appliances is primarily due to early correction of the buccal occlusion and overjet reduction through differential tooth movement, establishing a class 1 relationship that is maintained whilst normal condylar growth catches up. And there are different approaches, different appliances that we can use, the twin block and also the Frankel and also fixed one. But what is important is to choose the right appliance for the specific malocclusion. Let's see some case. These young guys suffered of class 2 malocclusion with a very severe deep bite, with a retrusive mandible that we have treated with a functional appliance first. Here you have the class 2, the full class 2 malocclusion on both sides, and the crowding caused by the deep overbite. We have imagined to forward the mandible, and what appliance we have used. We have used a Frankel appliance that used to change also the habits and the tongue position, reaching these results after the functional phase of treatment. And in this moment, we started with fixed orthodontics, ending the case with a good profile. And where is the trick? The trick is not only the therapy, it's also the maintainment of the therapy, because we maintain this case stable during the years by using bite planing composite on the palatal side of the incisors to maintain the correct bite, the correct deep bite. And this is the case at the end, and after the treatment with superimposition with the cephalometric analysis, and the case years after, it's still stable, and that's something very nice to show you. So I really agree with this article that today the field of orthodontics plays an important role in the diagnosis and treatment of sleep disordered breathing in young people. Because I personally treat different syndromes, sleep apnea syndromes in adults, and I don't know if one of you has ever wear this appliance. It's not easy to be weared, and also the CPAP is not easy to, doesn't give a very nice social behavior, social life. It's not nice to wear during the night something that make noise, especially for the partners. And the other a matter of, there are different articles that supports that sleep disorders, breathing, and can cause cardiovascular diseases, ictus 30 times more than in control cases, and cardiovascular risk and hypertension, systemic arterial hypertension. This is not nice to be weird in adults, and so let's think about what we can do as orthodontists. It's not only a matter of market, to open a new market. It's a way of acting as more as medical doctors than orthodontists. This article I published 2017 the results suggest that oral appliances have a definite role in treatment of snoring apnea in adults. But what we can do for children, growing children? Someone has published that could be done a maxillomandibular surgery in growing children, and that could be something that I would not do for my children. So why don't we try with the orthodontic functional treatment? Someone says that it's not clear the role of the mandibular advancement, but what we do when we validate the sleep endoscopy treatment, they advance the mandible with them as a prediction tool for treatment success of oral of MAD treatment, of oral appliance treatment. So the mandibular advancement, it's something that works. If it works in surgery, can work also in the normal life, and why not in growing patients? Of course, the absence of evidence does not mean the evidence of absence. So we have to study a lot on the and control the guys during the next 10, 20 years. But what about this guy? He comes to the office with this class 2 malocclusion, and the class 2 malocclusion in this case was primarily due to the position of the central incisor. He came with this, actually he came for an aesthetic reason. But I already knew that his father was an OSAS. And so I suggested him to do first an expansion and then a mandibular advancement. And he was very happy because I aligned the frontal teeth, but he doesn't know how much we have done for his growth. Let's give a look. The incisor, it's stopping the mandible, as we can see in this radiograph. And also the airways were very strict. CBCT provides also detailed three-dimensional images of the interfacial mass, but and is sometimes very widely used for evaluation of upper ways or in adult patients. But it should therefore not be routinely requested from an individual with a diagnosis of OSAS, especially if he's growing patient. So pay attention doing this. We already have of this patient all the records, and by using the teleradiography, we can do diagnosis of very strict, very reduced upper airways. And this is the father of Giovanni. Looks like him 20 years after. And the malocclusion is very similar. And he's lucky that the mandibular advancement with this appliance is working, because he is a candidate to surgery if not. And what we have done with him, we first start by expanding and advancing the mandible together with fixed appliance. This is the results at the end, with the perfect correction of class 2 malocclusion. and the transverse correction of the palate. Of course, he is very happy and he smiles and he is happy to have changed the smiles, but we know we have done something more. Here you can see the results in the teleradiographs, perfect angle of the incisor, of the lower incisors. We have worked both on the upper and lower jaw. And this is what is important. Important for him, correcting the smile and correcting the class 2. Because Giovanni came to the office because he didn't like the incisor. Because when he was smiling, the incisor was showed too much for him. And this is him after years of retention. Stable and still smiling, and we can see he has a reduction of the, how do they call it? The eye bars. Thank you. The occlusion, the functional occlusion is perfect. And here, let's see another case, very similar to the first one, with a very deep, very impressive deep bite and rotation of the upper molars that we have to derotate, and we have to then first derotate the molars and then advance the mandible. We of course use like the functional approach, and after that the fixed one. In this case, we can appreciate a very big, impressive growth of the mandible, very few changes in the upper jaw, and what is the best is that we have given space to the upper airways. This is the follow-up of him, and we have made it possible. So let's conclude this part of the speech that we have to give very important. We have to use the emotional reasons to give importance to the logical reasons. People come especially for emotional reasons, but can you imagine how important would be for the father of Giovanni to know that his son would probably not have the sleep apnea? Would be very important, and would be the way to let him start orthodontics. In Italy, we have a different way. We have a very different approach to the patient get not paid for the orthodontist get not paid for the treatment by the state. So patients come especially for emotional reasons, but to give medical reasons, it's very important for me to distinguish between dental ortho and specialist orthodontics. Of course, we don't like extraction because extraction is not associated to the maintenance of the correct arch form, and we are lucky that we can, comparing to Korea, that has a high extraction rate, and we have reduced very much the extractions, especially using specific braces. There are different options in the market to avoid the contact between the arch wire and the elastic ligatures, and to work with the good brackets. Of course, I really like the Genius one, and this is the real effect that we like. We like to change arch wires in this way by using low forces, super elastic wires, and self-ligating brackets, especially the passive one. We use the super elastic wires to have this case, for example, is a classical case that we would have treated by extraction 30 years ago. But now, after few months of treatment, I can say that this case has been treated in 6 months. We have solved the case in this way. this approach is the ecological one that I really like. The ecological with less is more is the one that use every kind of means we have to change the occlusion with less appliance that we can, and by using slicing and by aligning, and this means that people can have fixed orthodontics for a very few time, for very few months. What I mean, that less is more. For example, also with aligners, we guide the occlusion, and even if I don't like too much the aligners, we use it. And this is another case of a very nice guy that came to the office asking for aligning the teeth. He doesn't know that he has a premolar, a second premolar rotate, but we have to correct it. He will never notice it during his life, but that is important for the guidance of the occlusion and for the stabilization of the occlusion. And he would like to have the appliance only for 6 months before his birthday. What we can do, I told him, we first start with the less simple approach, with a mini implant, micro implant, as Dr. Moon said us, and it's very nice that I started using micro implants with the Abso Anchor, with the one of Dr. Moon 22 years ago. And we have done his birthday with this phase of treatment, with this step, and he didn't realize we were working, just moving, just rotating the premolar, and after this we have started using the Genius, going quickly, changing his arch form, correcting the bite, and going to the end with this guy very happy. You just need to clean better the teeth, and we have cleaned the teeth, and I'm sorry for the pictures, but this is the follow-up. So at the end, what I want to say to you, we have to change the smiles, but at the same time we have to act as medical orthodontists, because this is our field and that's what we like. Grazie. I want to say goodbye with this picture of my city, and that is the reason that for which I don't live in New York.